Hello and welcome to our Impact Program webinar. Today's presentation is colorectal cancer, an overview of genetics, family history, and lifestyle risk factors. I am today's moderator, Jillian Sotelo. During the presentation, we encourage you to use the chat box to engage with other attendees and panelists. Anything written in the chat box will have your name associated with it. All questions should be asked in the Q&A box on the top bar of your screen, which may be submitted anonymously or with your name attached. Questions will be answered at the end of the presentation. As a reminder, we are recording this event to be made available in the next few days on the Impact Program Cancer Care CSC site. Julie Goldstein, one of our Impact Program navigators, will be discussing today's topic with additional information about our program from our Impact Program leader, Kelly Nickelbein. Julie, thank you so much for joining us today.
Thanks, Jillian, and thank you to everybody for joining us during Colorectal Cancer Awareness Month for today's important discussion. The Impact team and I were very excited to see that I think we had record number of people express interest in today's webinar. So I ate my Wheaties, I had an extra cup of coffee, and I am ready to go. We have a lot of information to get through today. I just wanted to give you an overview of what our goals are. First, we'll be talking in general about what colorectal cancer is, the symptoms of these types of cancers, how we can have screening or diagnosis of colorectal cancer, factors that might increase the risk for colorectal cancer, as well as things that you can do to decrease those risks. Lastly, we'll wrap it up with a discussion of inherited colorectal cancer syndromes and discuss how genetic testing works to help us diagnose those syndromes. So to get started, we're going to do a very basic anatomy lesson. I hope this doesn't scare anybody away. We'll be focusing mainly on the colon today, otherwise known as the large intestine. You can see in this picture, the colon is the large tube that sort of wraps around the outside of the small intestine. Surprisingly, if you uncoiled a colon, it would be about 5 to 6 feet long. I stand about 5'1" on a good day, so that's always surprising to me how much can fit inside a little body. The main function of the colon in the body is to help move food through for digestion, as well as to pull the nutrients from the food that our body needs before waste is excreted. Okay, there are several different parts to the colon. I'm not going to spend a lot of time on this, but when we talk more about the inherited cancer syndromes, I want you to have a sense of the different parts of the colon because that will come into play. The first part of the colon or the large intestine is called the ascending colon. That's the right side of the colon, and that's where food starts its journey up through the colon. Next is the transverse colon, which is the part that goes across the top, which moves food from the right to the left side of the colon. Then, of course, the descending colon, which is the last part or the left side of the colon where food moves down towards the rectum to be excreted as waste. The very last part of the descending colon, that sort of S-shaped area, is called the sigmoid colon. And then, at the bottom is the rectum. The rectum is about the last 5 to 6 inches of the colon. That's where the waste is sort of held in storage until it's excreted. So again, just main thing to know, the colon is the part of the body where food moves through so we can absorb nutrients and then excrete what we don't need as waste. This is a picture of the inside of a colon. I wanted to show this picture to give you a better idea of what it means to have a cancer within the colon. So just like any other tissue in our body, the colon is made up of cells which grow and divide in order for the colon to be healthy and to function properly. Sometimes, however, if those cells grow and divide at an abnormal rate, or if some unhealthy cells which should die don't die, we can have an accumulation of abnormal cells, which develops into a cancer. And this is the same process that we see in other types of cancer, like breast cancer or lung cancer. Same idea, but today we're talking about within the colon. The picture of the colon cancer is the one on the bottom where you see the red clump of cells. You can see that compared to the nice, clean, smooth tissue, which is normal colon cancer tissue. The top picture, we have a picture of colon polyps. If you can see, again, there's a lot of just nice, smooth looking colon tissue. But towards the bottom right, you see those three little bumps. Those are colon polyps. So colon polyps are basically a clump of cells that form on the inside lining of the colon or the rectum. They can sometimes be completely benign, meaning non-cancerous and no potential to develop into cancer. But sometimes if these polyps are left in the colon too long, they do develop into a cancer. We see that almost all colon cancers, again, that bottom picture of the red cells on the bottom, almost all colon cancer starts out as one of these polyps that eventually grows and divides too quickly into a colon cancer. Let's talk about symptoms of colorectal cancer. Sometimes people who have colorectal cancer don't have any symptoms, but these are some of the main symptoms that we can see. I always like to point out anytime I talk about symptoms of any type of cancer, not to panic if you are having any of these symptoms. Almost everything on this page can also be seen as part of a different medical condition or just even a normal process in the body. I do like to emphasize, though, if you are experiencing any of these symptoms, it's something definitely worth speaking with your physician about to determine if it's anything to be concerned about. One of the first symptoms we can see with colorectal cancer would be a change in bowel habits. So that means if we're seeing persistent diarrhea, persistent constipation, sometimes people describe a narrowing of the stools where the stools almost are like the size of a pencil rather than their normal size. And we're talking about a persistent change. So this wouldn't be like you had a stomach virus and had diarrhea for a few days, or you were in a car accident and got put on pain medicines that make you constipated. This would be something that lasts for at least a week or two, and there's nothing else you can really attribute those change in bowel habits to. I think most people have heard about concern if there's blood after a bowel movement. Sometimes that can even, just be on the toilet paper after you've had a bowel movement, or you might even see blood mixed in with the stool or blood in the toilet. Again, commonly seen with harmless things like hemorrhoids, but can be a concern for colon cancer. So definitely something to get checked out if you're experiencing that. Abdominal pain. You remember from that very first picture I showed you of the colon, it really stretches over the right, middle, and left side of the body. So abdominal pain associated with colon cancer can really be experienced anywhere. So there's not a specific spot that would be more or less concerning for colon cancer. Loss of appetite. So that would be if you're just not as hungry as you usually are, or sometimes people experience it as getting full more quickly. So whereas, you used to have to eat a lot more to experience that feeling of fullness, sometimes with colon cancer, it might take a lot less to make you feel satiated. Persistent lethargy, which is just a fancy scientific word of saying tired. I always joke I'm a mom of three. I have a full-time job. I'm pretty busy, so I always feel pretty tired. But this is a different type of tired. This is having trouble really making it through your daily functions or, just making it through your day. And also persistent, meaning this is every day, all day. So not something like, you stayed up really late and are catching up the next day on sleep. This is a significant amount of lethargy. Some people might also experience looking pale or jaundice. Jaundice means yellowing of the skin. Sometimes jaundice is seen first in the whites of the eye, which could indicate a problem with the bile duct or the liver that could be associated with colon cancer. Lastly, unexplained weight loss. So unexplained means you're not trying to lose weight. So this is not weight loss associated with a new eating regimen or exercise regimen or based on taking weight loss medications. This is really you are following the routine that you've always followed, but you're losing weight for reasons that can't be explained. Now we can talk a little bit more about what types of screening and diagnostic tests are available for colon cancer. So there are general guidelines for the general population of when and how to start colon cancer screening. But I do encourage everybody to speak with their own physician about what's right for you. Sometimes people have just different risk factors, both personal or family history factors, or are experiencing symptoms. So their physician might have a specific regimen for them. So really important to communicate with your physician about when and how you should start screening for colorectal cancers. I'm going to go through a couple categories of the screening tests today, but really not going to go too in depth. First, we have stool tests. These are screening tests. So that means these cannot diagnose colorectal cancer. So you can't have this test and get a result that says you have colorectal cancer. There are a couple different versions of stool tests. Each one has sort of its own thing that it's looking for. There are some that look for blood in the stool or occult blood, which means blood that you can't even see with your naked eye, but might be mixed in with your stool. There are some that looks at DNA within the stool that can be an indication of a colon cancer or a polyp. And some stool tests use a combination of the blood and DNA. Anytime somebody has an abnormal stool test, likely they would have to go on to have additional testing to confirm a diagnosis. And the third picture, we have a picture of a colonoscopy, which is the gold standard for colon cancer screening. So this is a test where something called a colonoscope, which is a flexible tube with a camera on the end, is inserted through the rectum and goes the whole way through the large intestine. So it goes from the rectum all the way through the ascending colon. This does require prep, meaning that your colon has to be cleaned out prior to examination, and you are under sedation during this process. And this really is a camera into the inside of your colon where a physician can take a good look for any polyps, cancers, or any other abnormalities within the colon. Uh, the second picture is a flexible sigmoidoscopy, or some people call it flex sig. Very similar to a colonoscopy, except you're only looking at that part, the left-sided part of the colon, the sigmoid colon. So it's, again, similar to the colonoscopy where we're using a scope with a camera, we're looking within the colon. We are able to see any polyps or cancers, but, excuse me, we're not going the whole way through the colon. One very important distinction about the flex sig and the colonoscopy is that these are diagnostic tools. So that means not only can a physician see a polyp or a cancer through the scope, they are able to remove that polyp or take a biopsy of the cancer, send it to a laboratory, and you can get a definitive diagnosis. We also like to say that these tests can be used as colon cancer prevention. If you remember, we had talked about how typically colon cancer develops through a polyp that then further develops into a cancer. If somebody has a polyp on colonoscopy, that polyp can be removed, preventing it from developing into a colon cancer. Last is CT colonography, also known as a virtual colonoscopy. So this uses CT images to get a look at the colon, same as the colonoscopy that requires prep to clean out your colon. This, however, cannot be used as a diagnostic tool. So even if they see what looks like a polyp or a mass on the CT scan, they still need to go in and do an invasive procedure like a colonoscopy to remove that tissue, determine if it is a polyp, what type of polyp, or if it's a cancer. Again, speak with your physician about the best time and the best way to start colon cancer screening, colorectal cancer screening. Okay. As far as risk factors for colorectal cancer, so we know in the general population in the United States, the chances of developing colon cancer, is somewhere between 3 to 4% in a person's lifetime. There are certain factors, however, that can modify those risks. Um, Again, just like I was saying with the symptoms of colorectal cancer, you have to look at the whole picture. So technically, really a person's risk of colon cancer is based on many of these different factors playing together. There's no single factor that is really going to be the sole thing to cause somebody to develop a colorectal cancer. The first factor that I want to talk about is age. I know many of you have probably heard all this recent buzz about colon cancer rates really increasing in younger people, and that's true. We have definitely seen that trend. We know, though, that still 90% of colon cancers do develop in people over the age of 50. As far as other risk factors, excessive use of alcohol and tobacco can increase colon cancer risk. We know that's true for many other different types of cancers and also for other health-related concerns. Low fiber diet. So that means less than ideal consumption of fruits and vegetables and whole grains. That is a factor that can increase colon cancer risk, as well as consumption of a lot of processed meats, processed foods, and red meats. Again, all in moderation. That doesn't mean it needs to be cut for your diet, but that does play into colon cancer risk. A high body mass index can increase risk. We also know that people with inflammatory bowel diseases, such as Crohn's disease and colitis, can have a higher chance of developing colon cancer. I always like to take a second right here to distinguish that between irritable bowel syndrome. So IBS, irritable bowel syndrome, is not a risk factor for colon cancer. However, IBD, or inflammatory bowel disease, again, such as Crohn's and colitis, does increase colon cancer risk. Lastly, family history of colorectal cancer. Like I said, we're going to go much further into that. So there are some families that have an inherited high risk for the development of colorectal cancer. Even in families that don't have this inherited genetic factor, might have one or two family members with colorectal cancer, which in itself can slightly increase a person's colorectal cancer risk. So it's important to take a look at these factors, see if you have any of them, and again, speak with your doctor about it to determine the best screening for you. And just as we know there are risk factors for the development of colorectal cancer, there are some steps that you can take to modify those risks. So obviously there are some risk factors that you can't modify. You can't modify your age, you can't modify your family history, but there are some of these risk factors that you can modify, such as getting regular exercise, eating healthy. Again, that means getting more fruits, vegetables, fiber containing foods, whole grains, which can play a role in reducing colorectal cancer risk. Cutting out smoking, which, as I mentioned before, is so important for your health in general and for reducing the risk of other types of cancers, not just colorectal cancer. Drinking in moderation. So the recommendations aren't saying that you need to completely cut alcohol use, but the current thought is if you do drink alcohol, it's best to limit it to 1 drink a day for women and 2 drinks a day for men. Also, maintaining a healthy weight. As I had mentioned, increasing BMI is a risk factor for colorectal cancer. So, doing what you can to maintain a healthy weight can potentially reduce your risk. Okay, now we're going to get into the nitty-gritty of hereditary colorectal cancer. So we're completely changing gears now, where we're going to be talking about the family history aspect that can contribute to colorectal cancer risk. So you can see from this pie chart, most colon cancer, about 65%, develops sporadically or by chance, or for a combination of those risk factors that we were talking about earlier. We know that about 15 to 20% of colorectal cancer is familial. That means that there might be a clustering of it in the family, but there's not one of these single gene mutations in the family causing a very high risk for the development of colorectal cancer. That's what that last 5 to 10% of the piece of pie is referring to. That's considered inherited colorectal cancer. I'm going to talk more about what I mean by that, but basically these are people who have a genetic condition that's being passed down through the family, causing a significant increase in colorectal cancer risk. Okay, so before we get into the specific syndromes, just want to remind you what I mean by a gene and a gene mutation. A gene is a piece of DNA that gives the body information on how to do a specific job. In general, we have 2 copies of every gene. 1 gene comes from our mother, 1 gene comes from our father, and again, they're passed down to us. A mutation is a mistake in that gene that makes the body unable to do the job it's supposed to be doing. So just like our genes are passed down to us from our parents, if there is a mutation in one of those genes, that could also be passed down to us from our parent. When we talk about inherited colorectal cancer, and for the most part, inherited cancer in general, a very simple way to think about it is we have some genes in our body whose job is to protect us from developing cancer. If there's a mutation in one of those genes, the body is less able to protect us from developing cancer. And in the case of an inherited colorectal cancer syndrome, we are at higher risk for the development of that type of cancer. So now we can talk more specifically about 3 colorectal cancer syndromes. There are many more than 3, but we don't have all the time in the world, so I'm hitting on the big 3 today. And obviously, if you have any questions or concerns about any of the other inherited colon cancer syndromes, you can always let us know. First, I want to talk about Lynch syndrome. This is actually the most common hereditary colorectal cancer syndrome, and in general, the most common hereditary cancer syndrome. About 3 to 5% of all people with colon cancer have Lynch syndrome. Lynch syndrome is a little unique in how it presents, and we can get some clues from family history to determine whether or not we think somebody might have Lynch syndrome. Again, it's about 3 to 5% of all colorectal cancers, so that's a pretty significant amount. So it's important to take a look for certain features that might indicate to us that a person has Lynch syndrome. Not only is Lynch syndrome associated with inherited colorectal cancer, it also shows endometrial cancer and other types of cancers, which I'll get to on the next slide. But the main concerning features for Lynch syndrome in a family would be if we see more than one person in more than one generation with colorectal and/or endometrial cancer. One of the hallmark features of Lynch syndrome would be an earlier age at these cancer diagnoses. So if we're seeing a colon cancer or an endometrial cancer before the age of 50. If somebody had a history previously of colorectal polyps, typically with Lynch syndrome, we would see less than 10, but having colorectal polyps, especially if they developed at a younger age, can be concerning. Right-sided colon cancers. So if you remember at the very beginning, I was showing the ascending colon and said that's the right side of the colon. That is not, and I'm speaking very generally, so there are always exceptions, but the right side of the colon typically is not where sporadic cancers develop. Most of the time, cancers unrelated to Lynch syndrome develop on the left side. Most of the time, cancers related to Lynch syndrome develop on the right side. Now, I definitely have seen families with Lynch syndrome with colon cancer on the left side, but that is one of the well-known features of Lynch syndrome would be a right-sided colon cancer. Also, in families with Lynch syndrome, we might see people who have had more than one cancer in their lifetime. So sometimes we see people who may have had more than one colon cancer, or maybe a woman who's had a colon cancer and then an endometrial cancer. You can see from that pie chart I have here that there are multiple genes associated with HMPCC, MLH1 and MSH2 being the most well described, or the ones that most commonly contribute to Lynch syndrome. All of these are dominantly inherited, meaning you only need to have one copy of a gene mutation in order to have Lynch syndrome. And even though anybody who has a mutation in any one of these genes has Lynch syndrome, the risks for the cancer really depend on which gene has the mutation. And that comes into play when we talk about screening recommendations, medical management recommendations, really depends on which gene has the mutation. In general, surveillance for people with Lynch syndrome will involve colon and endometrial cancer screening or discussions regarding preventative surgeries at younger ages and higher frequency than the general population, but again, really depends on the gene involved. In addition to colorectal and endometrial cancer, we can see other types of cancers and growths associated with Lynch syndrome, brain cancers, specifically glioblastomas, sebaceous carcinomas, which are specific types of cancers of the skin. We can see cancers in other parts of the GI tract, like the stomach or small intestine, specific types of urinary tract cancers, pancreatic cancer. We had mentioned the endometrial cancer. We can also see ovarian cancer with Lynch syndrome. On the left side, you can see I have the different genes listed and the risks for colon cancer and endometrial cancer, depending on which gene is involved. I know we could spend all day talking about Lynch syndrome, but I think we're going to move on to talk about familial adenomatous polyposis and attenuated familial adenomatous polyposis. This is quite a mouthful, so you can see why we call it FAP or AFAP. Completely different animal than Lynch syndrome. The only thing really it has in common with Lynch syndrome is it is also a dominant condition, meaning you need to have just one mutation in the gene passed down from your parent to cause FAP. As opposed to Lynch syndrome, where we might see 1 to 10 colon polyps, people with FAP or FAP is characterized by having hundreds to thousands of precancerous polyps called adenomas throughout the GI tract. You can see in this picture here, this is what the colon tissue on colonoscopy would look like for somebody with FAP. You can see it's all lumps and bumps. There's really very little smooth colon tissue. It's often described as a carpeting of colon polyps. These polyps are mainly in the colon and the rectum, but they can sometimes be seen in the stomach and small intestine. And the another key difference between FAP and Lynch syndrome is that these polyps can really start developing at a young age. Sometimes as young as 10 to 12-year-olds can be seen having polyps if they have FAP. AFAP is very similar to FAP, except it's a little milder. So typically these people have less than 100 polyps, again, mainly in the colon and rectum, can be in the small intestines and sometimes in the stomach. What's also interesting about FAP is we can sometimes see features that you would never in a million years imagine to be associated with colon polyps or colon cancer. Sometimes, FAP can be diagnosed by a dentist or by an eye doctor because of these other features that might appear. You can see the picture of the jawbone on the bottom left with that growth on it. That's called an osteoma. It's basically a lump or a bump that grows on the skull or the jaw. We can see specific cysts on the skin, dental changes, specifically extra teeth. You can see on that dental x-ray at the bottom, there are extra teeth. I always say that's what my kids' teeth look like before they got their palate expanders. Sometimes we can see non-cancerous tumors in the abdomen called desmoid tumors. What's also really interesting is we can see something called chirpy, which is really only seen in FAP. That stands for congenital hypertrophy of the retinal pigment epithelium. It's something that only an eye doctor can see through a dilated pupil, and it basically looks like freckles on the inside of the eye. Again, clues that somebody might have FAP that really have nothing to do with the colon rectum or other GI parts. As I mentioned, FAP is also a dominant condition, different from Lynch syndrome that we know of only one gene involved, and that's the APC gene. I had mentioned before that FAP can develop, the symptoms of FAP can develop in childhood. So we actually recommend genetic testing by age 10 to 12 for FAP, by teens for families where we know there's AFAP. And interestingly, the colonoscopy screening can start as early as age 10 in FAP, and in the teens and AFAP. Upper endoscopy, where they stick something similar to the colonoscope, except it's called an endoscope, through your mouth down through your esophagus, your stomach, into the first part of your small intestine. That's done also starting around age 20 to 25, looking for polyps that can be in the upper GI tract. One very important thing to know about FAP is that eventually almost everybody with FAP will go on to develop a cancer in the colon and rectum if the colon is not removed. So at some point during the lifespan of somebody with FAP, their polyp burden might be too much for a physician to follow on colonoscopy, and that leads to preventative surgery of the colon. Okay, I'm going to speed up because I think I'm covering too much information, not fast enough. So I'll speed up a little bit. Last syndrome I want to discuss is something called MUTYH, or MUTYH associated polyposis. It's very similar to FAP. The one thing that I want to point out about this, it's sort of our black sheep that we're discussing today, because this condition is recessive. So that means that it necessitates two mutations for somebody to have this condition. So you have to inherit a mutation in MUTYH from your mother and a mutation in MUTYH from your father to have this condition. Clinically, it's very similar to FAP or AFAP. And the screening and medical recommendations are similar to what we would see in FAP. Okay. So I just went through some of the common inherited colorectal cancer syndromes. I know it's a lot of information. Just want to do a very quick review for you of what you should think about when determining if your family might benefit from doing genetic counseling or testing for inherited colorectal cancer. Certainly, if you see anybody in the family with early onset colorectal cancer or polyps, especially before the age of 50, if you're seeing two or more family members with the same type or related type of cancer, if there's somebody in the family who's had more than one cancer in their lifetime, someone who's had 10 or more adenomatous polyps of the colon or rectum, rare types of colon polyps. So there are many other different colorectal cancer syndromes that we didn't discuss today. Some of those are associated with very specific types of colon polyps that a doctor would tell you if you had a colonoscopy and they found other types of cancers in the same family as colorectal cancer. So we talked about some of these that can be seen with Lynch syndrome as well as FAP, and then other non-cancer skin findings such as those dental changes, bone lumps or bumps, the eye findings, all of those things could be consideration to talk more about genetic testing. And I'm then going to just wrap up quickly by telling you how genetic testing works. So if there is concern about one of these or a different inherited cancer syndrome in your family, it is possible to look at your genes to see if you have one of these mutations that can increase cancer risk. Typically requires a blood or saliva sample, analyzes multiple genes at one time, which is also called panel testing. So we're looking at a panel of different genes. Sometimes we can look at almost 80 genes at one time. This type of testing is most informative if starting with a family member who has been affected with cancer or other signs of an inherited cancer syndrome. That's not always possible, but that's the ideal situation. If a person in a family has a mutation, all first degree relatives or children, siblings have a 50% chance of having that same mutation. Okay. Jillian, do you think we have time to do our activity?
I think we can at least do maybe one or two.
Okay. So I thought it would be fun at the end for us to do a little quiz to see how much you remember from everything we talked about today. So Jillian's going to set up a poll. We have never done this before, so if it doesn't work, sorry that you guys were our guinea pig. We'll figure it out next time. So I'm putting up what's called a pedigree or a picture of a family tree, and we want you to guess what inherited colon cancer syndrome you think this is. The only hint I'm going to give you, it is one of the three that we talked about today. So
And
in this oh, go
yeah,
ahead.
just so you guys know, the box will pop up, and I know it will. You won't be able to see the pedigree. If you close that box and go into the chat, you can look at the pedigree and answer there as well.
Okay, thanks. So in this picture, the person and again, this is made up. This is nobody that I've ever met with, but the circle is a woman who was diagnosed at a young age with endometrial cancer at 39. She has two siblings who have been found to have colon polyps at young ages. One was found to have 3 polyps at 35 years of age. One was found to have 7 polyps at 45 years of age. Her father had colon cancer at 43, as well as her father's sister had colon cancer at 40 and passed away at 43. And then she knows that her father's mother had some sort of female cancer, but she does not know what type. So Jillian has it in the chat. Take a guess at what syndrome you think this is.
Looks like we have a few more responses coming in, but overwhelming, it looks like Lynch syndrome was the answer.
Great. I did my job, guys. So that's exactly right. So the main thing to take away from this is we're seeing early onset endometrial cancer in the same family with colon cancer as well as colon polyps. Should I do one more, Jillian?
I think we might be a little bit tight on time, Julie,
Okay.
and we want to make sure there's quite a few questions in the chat that we get to those.
Okay. So let's move on to Kelly, who is our Impact Program Director, who's going to talk a little bit more about the Impact Program before we get to the Q&A.
All right, great. Thank you so much, Julie. Welcome, everyone. Thank you for attending this presentation. I'm seeing a lot of discussion in the chat and people sharing their own personal situations and their family members, and that's really appreciated. And so what I'd like to do is talk to you a little bit about our program that is part of Thermo Fisher Benefits. We are here to support both individuals who have a cancer diagnosis, but also those who do not and might be concerned about their own family history. Julie, Jillian, and I are all navigators for the Impact Program, and we are genetic counselors by training. And so our special expertise is really with cancer genetics and identifying whether or not there may be a genetic syndrome in a family and discussing the option for genetic testing, when it might be appropriate, and discussing results after and what to do about them. We can also discuss family histories without a genetic mutation and talk about what the screening recommendations might be in collaboration with your healthcare providers. And so with that being said, this is a voluntary and free benefit for both employees and their family members that are on a Thermo Fisher medical plan. So that would mean your healthcare insurance, like the national plan, which is United Healthcare, or the local plans such as UPMC or Kaiser. We have several different services. As I mentioned, the three of us are navigators. We serve as your single point of contact to answer questions and provide that general guidance and resources. We can connect you with other services that are provided that may be helpful, including expert medical second opinions for someone who has a diagnosis, navigating other benefits that you may not be aware of that could be helpful. As I mentioned, the genetic counseling about cancer risks, and then really, because we've been doing this for Thermo Fisher for over 10 years now and worked with lots of families, we have accumulated quite a bit of resources that we would be able to share, again, just based on individual circumstances. Okay, next slide. As I discussed, the qualifications are pretty simple. It's really anyone who's on a Thermo Fisher medical plan. You do not need to have a cancer diagnosis to enroll. Okay, next slide. If you are interested in enrolling or talking with one of us, what we would ask for you to do is email us at our shared inbox, which is impact@thermofisher.com. All we need is your name and your email address, which will come from when you send it. What will happen at that point in time is I will respond with information about the Impact Program and then send in a separate email our electronic enrollment form. We would ask that you read through that form and submit it online. Once we receive that, then I will connect you with your navigator and instructions on how to schedule your first introduction call. It's fairly simple. Like I said, all you need to do is email us and I will take it from there. Typically, after these webinars, we have more individuals contacting us than usual. So I would just ask to bear with me. I'll get back to you as soon as I physically am possible with providing you the enrollment form. If it seems like a day or two has gone by and I have not responded, it might mean that maybe I missed it. Please email me again. That doesn't happen very often at all, but I'm human. So please keep up. If I don't respond to you in 24 hours, please send another email. All right, next slide. If you're interested in learning more about the Impact Program, you can find us on the Colleague Service Center site, and you can just search for Impact. If you have trouble finding it, just let us know. We also have a site on My Benefits as well, and that'll provide you with all of the recordings from prior webinars. This one will be up in a couple of weeks, but you can see all the past ones on different cancer diagnoses, as well as a few other resources just for educational purposes. All right. And with that, we're going to open it up for questions. So I'm going to have Jillian be our moderator. She's been keeping an eye on the chat and the questions. Just as a disclaimer, As Julie may have mentioned in the beginning, we are not physicians, we are genetic counselors. So when we can't answer a question, we'll let you know and maybe provide the place where you can potentially find it, or we may suggest that you reach out to us individually and enroll in the program. So Jillian, if you would like to start with questions or themes that are coming up in the chat, we'll do our best to answer.
Great. Thank you, guys. A big sort of conversation that's going on in the chat, Julie, is who all you include when you look at a family history. Are we talking about cousins? Are we talking about aunts, uncles? How, what degree of relationship do we look at when we consider family history?
That is a great question. In general, I like to have parents, aunts, uncles, grandparents. Um, However, it is helpful if you have information about cousins as well. Not everybody has all of their family history information, so we, go with what you have available. But we're really looking for patterns within the family. So having certainly at least 2 to 3 generations is helpful.
Yeah, such a good point. Another question that has come up is, can you talk a little bit about the general screening guidelines for colon cancer? As you know, they recently changed. And
Right.
also, what may cause there to be deviations or for a doctor to recommend that a colonoscopy be done earlier or more frequently?
Great question. So the general colon cancer screening guidelines recently have changed. It used to be starting at age 50. Now it's age 45. Um, and it really, so some people recommend starting with the stool sampling. Some recommend starting with the colonoscopy. As far as differences and frequency and age at which you start, that's really based on your risk factors as well as, if you're having any symptoms. So I'll give an example. If you have somebody in your family who was diagnosed with colon cancer at age 52, generally we say start colon cancer screening 10 years prior to the youngest diagnosis in the family. So that would mean start at age 42 rather than 45 as recommended in the general population. I know that
Okay.
was a very general answer. Does that help?
I think so. Yeah. And I think, also, as you had mentioned, there was a few people that had commented that they had some personal history, such as like IBS or other GI issues that had caused there to be earlier colonoscopy for other reasons.
Yes, correct.
And I'll just add, sorry, I just want to add in terms of frequency, that also is dependent on both your personal factors and also if anything is identified on a colonoscopy at the time you have it. If nothing is identified and you're in the general population category, typically it's every 10 years for colonoscopy, but that can be moved back if they have to remove polyps or see anything else that might be concerning. And that can be moved back to, every 2 to 3 years, every 5 years. It just, again, they take in the big picture when deciding how frequent that needs to happen.
Yeah. And, I think one of the most helpful slides in this deck that I really love, Julie, is the one on symptoms, right? So if you're having any of those GI symptoms, we really recommend that you talk to your provider. We certainly have seen younger people with colon cancers. And oftentimes, if you're having those symptoms, one of the things that they'll say is, let's go ahead and do a colonoscopy and see if anything's going on, even if you're under the age of 45. So I love that slide because I think it's just a good reminder of what to watch out for.
Yes, absolutely.
Julie, another question that came up is, can you talk a little bit about how sort of the polyp to cancer pipeline works?
Sure. So again, usually you're going to start out with normal colon lining that eventually could develop into a polyp if there are cells that grow abnormally or at a faster rate than they're supposed to. And then if that polyp is left within the colon, it can develop into a cancer. Not all polyps have that propensity or likelihood to develop into a colon cancer. There are only some types that can. But again, if a colonoscopy is done and polyps are removed, that stops that process of continuing on to grow into a cancer in the body. There There's a lot of reason for us to believe that that process, that going from a polyp to a cancer, happens a little more quickly in somebody with something like Lynch syndrome or FAP compared to somebody in the general population. Most colon cancers do develop in that way, that start out with a polyp and then eventually develop into a colon cancer. There is some thought too, particularly for people with Lynch syndrome, is that step might not be as clear as it is in the general population, where there might be normal tissue that progresses into a cancer without necessarily having that intermediate polyp step.
Yeah, such a good point. And then also, Julie, I think you still have control of the slides. If you don't mind going back to the symptoms slide, there's been a couple requests for it. And just while you're doing that, another question that had come up is, can you talk a little bit about, the genetic testing that's available for cancer genetics versus like looking at genetic testing, for instance, for previous, I'm sorry, for other types of colon issues like IBS?
Let me pull up the symptoms. Can you say that again, Jillian? I didn't understand
Yep. So
the
can you talk a
question.
little bit about the difference between genetic testing for inherited cancer risk versus some of the genetic testing that might be available for IBD, IBS?
So as far as I know, there's no genetic testing for irritable bowel syndrome. So genetic testing for inherited colon cancer syndromes would be looking at the genes that we know are associated with those syndromes. So for example, looking at the genes that we know are associated with Lynch syndrome or FAP. We do know with inflammatory bowel diseases such as Crohn's and colitis, those can run in families. I am not aware of what type of or what genes would be evaluated for those, but it would be different genes than those that we see with the inherited cancer syndromes that we talked about today.
Okay, another question has come up just about the risks for getting a colonoscopy. And then can you talk a little bit more about what happens during, not during what happens during colonoscopy, but a colonoscopy versus a stool test and some of the differences between those two?
Sure. And I'll give the disclaimer again that I am not a physician, so I'll do the best I can to give you general information. But for the specific risks and risk numbers associated with colonoscopy or invasive screening, I highly recommend that you speak with a gastroenterologist, or that's a physician who performs the colonoscopy to give you more specific information. Again, the stool tests are a screening test, so that means you're given a collection kit to collect your own stool sample at home. It's sent to a laboratory, and then the laboratory uses that stool sample to look for, again, depending on what type of test is being used, any hidden blood within the sample or any changes within the DNA of the stool that might indicate that there's a cancer or a polyp. These are not diagnostic tests, so it could come back saying, based on the results, there is blood in your sample, or the DNA pattern suggests you possibly have a colon cancer or a colon polyp. But you would need to go on to have a procedure like a colonoscopy in order to diagnose whether or not there's a polyp or a cancer. The colonoscopy procedure, typically a day or so before you have the procedure done, you're given what's called PrEP. And that's typically a liquid that you drink that helps you completely clean out your colon. So there's no stool in the colon when the physician looks at it. You are sedated during the procedure. Typically, it's a conscious sedation, so it's relatively easy to go under and easy to wake up from it. Again, there are variations in this, so always talk with your own physician about it. But then once you're sedated, they do insert a tube called a colonoscope with a camera on the end, and that, seeing if I have the picture, and that camera then produces a picture like this of the inside of your colon, where they can see polyps, they can see any masses like a colon cancer, and then remove them if they see it. And then it can also be used to look for other things or other problems in the colon, such as Crohn's disease, colitis, diverticulitis. These are all things that can be seen on colonoscopy. And that's considered, again, to be a diagnostic test, because if they see mass in the colon, they can take a biopsy of it, and then you would get a result of whether or not it's cancer.
Okay, great. All right, so I'm trying, okay, so another question about cancer genetic. Oh, I'm sorry, about the stool test. So if a stool test
Sure.
is negative, should somebody get another test like a colonoscopy?
That would be something certainly to review with your physician. That's, a hard question to answer without knowing your personal risk factors or your any other concerns that you might have that led you to have the screening. That would be definitely a discussion to have with your physician.
Okay, I think that we have answered most of these questions. There's another question that came about genetic testing. Is the genetic testing for all cancers or diseases? I think you had mentioned that there is genetic testing for a number of things, but just to be clear, the IMPACT program specifically only does cancer genetic testing. So we only do genetic testing related to cancer risk. If you might be able to find a genetics provider in your area for other types of genetic testing for non-cancer related issues. And then another question came up about 23andMe and other online genetic testing. Julie, would that have been identified on those tests, typically the genetic syndromes we talked about?
No, so typically 23andMe and those similar testing platforms are mainly used to determine ancestry. Some of them did have some basic genetic testing for certain types of heart disease, very, very basic genetic testing for a couple inherited breast cancer syndromes, but no, definitely not the conditions we talked about today. And I would just caution you, if you are concerned about inherited breast cancer risk, if you did have 23andMe or any of those other direct to consumer testing, that would not be considered an adequate evaluation for inherited breast cancer or any of the other conditions that it tests for.
All right, great. So we are actually out of time. If people have additional questions, please put them in the chat and we'll try to answer them as we can. Again, today this will be was recorded and it will be posted on the IMPACT website on the Colleague Service Center. The link to that can be found at the top of the chat. Additionally, you can find out more information about our program there. To contact us, you can always email us at impact@thermofisher.com. Thank you, Julie and Kelly, for giving us all this information. And thank you, everyone, for attending and for asking all the questions. Have a nice day.